Hi, Assalamualaikum. I am Yasmin binti Awaluddin. Will be presenting the tasks that have been given by Dr Ida Hasni Shaari in order to address the first course learning outcome, which are to describe the principle of human development, the concept of motor control, and motor learning, as well as ICF model in pediatric rehabilitation. There are two articles that have been assigned. The first article entitled A Motor Learning Therapeutic Intervention for a Child with Cerebral Palsy through a Social Assistive Robot by Butrago et al., while the second article is entitled Home-Based Bimanual Training Based on Motor Learning Principles in Children with Unilateral Cerebral Palsy and Their Parents, the COAD Study, Rationale and Protocols by Schneckers et al. Based on the following articles, a critical evaluation has been made on the evidence of intervention that integrate the motor learning principles for children with cerebral palsy through comparison of content between the two articles and synthesizing the outcomes of both studies. But first of all, what is motor learning? Motor learning can be defined as an array of internal processes associated with practice and experience, which in the context of acquisition of a specific skill, that will lead to a relative permanent changes in how motor activity is elicited. Generally, a motor learning principle is used in therapy programs in clinical practice by inducing the learning components to enhance muscle memory on a particular movement, specifically in children with disabilities such as cerebral palsy. Okay, what is cerebral palsy? Cerebral palsy can be described as a group of permanent disorders in the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occur in the developing fetal or infant brain. There are several definitions published by different authors, but overall they come out with four elements in common, which are disorders of movement or posture leading to motor impairment that develop very early in life and can be attributed to cerebral abnormality. And although the clinical signs change with the child development, the cerebral abnormality neither resolve nor deteriorate. Studies by Blair and Keynes reveal that CP is a man-made construct defined by clinical description rather than by any objective biological, etiological, or anatomic criteria and should not be considered as a diagnosis. The article on intervention through social assistive robot aims to validate the effectiveness of a physical therapy program to improve the participation and fulfillment of therapeutic objective for motor learning to walk using a social assistive robot to increase the number of steps of the child without falling. As for the home-based bimanual training, the COAD study stated their trial's objective is to improve the bimanual skills of the child while minimizing the increase of therapy-related parental stress. For the study design, Butrago et al. Used a single case study design as this will help the researcher to examine in depth of only one person with specific lesion at one time by closely track and report the changes at the level of individuals. Therefore, this will help to provide a high quality of experimental research. Schneckers et al. Use Co-Creation at Hand, The Road to Independence COAD, a mixed methods embedded design that consists of a comparative case series and a process evaluation, and these trials were mostly related with home-based training approach. This will help the researcher to identify the clinical pattern of a particular disorder. As for this study, it involves the recruitment of children with unilateral spastic cerebral palsy. For social assistive robot case study, the setting takes place in Surgery Neuro Rehab Center of Columbia. It has been reviewed by Kharkiv on 2020, where children with cerebral palsy will perform better in clinical setting as it is easier to identify any problematic factors or barriers to walk immediately throughout the treatment intervention. However, the environment and tasks will be less variety as the treatment program will only limited to rehab gym area. Even though home-based care was more cost-effective compared to center-based care, some therapy programs may not be feasible to done as some of parents may indicate that it was difficult to find enough hours in a day to perform the treatment, which may lead to difficulty to incorporate with the program. The study by Butrago et al. Included a participant who is an 8-year-old boy with dyskinetic cerebral palsy and level 3 with all the following. First is Gross Motor Function Classification System, GMFCS, which indicates the children are able to walk using a handheld mobility device. Second is Manual Ability Classification System, MACS, which shows that the children are able to handle objects with difficulty, needs help to prepare and modify activities. And third one is Communication Function Classification System, CFCS, which the children have the ability to sense and receive information with familiar partners effectively, but not with unfamiliar partners. The children also noted with no any other health complications and able to interact with environment and understand immediate context. The authors take appropriate methodology on recruitment of the participant by using the 3 outcome measure as baseline, where it provides a view of overall functioning in a child with CP on 3 domains: mobility, upper extremity function, and communication. By using this baseline, the study outcomes could produce a more standardized and generalizable result in that particular population of the research. Children with dyskinetic CP also exhibit limitation in gross motor function and manual ability, but better abilities in communication, so there may be no issues on less exposure for social interaction. For home-based bimanual training, the participants of the study include unilateral spastic cerebral palsy, age range between 2 to 7 years old. The participants also present with level 1 to 3 of MACS and GMFCS, as these both outcome measures has been shown to highly correlated and were both significant predictors of self-care development and level of independence. Now, we will move on to the study procedure. For the social assistive robot, it starts with recognition section, where the child and robot met for the first time and perform greetings and random movements of head and upper limb. This recognition section is important to prevent negative impact on first therapy session that will lead to distraction and lost interest to attend therapy. This intervention consists of 16 sessions, 2 weekly sessions of 45 minutes each. First session comprised of conventional therapy on motor skills, while the second session include motor learning to walk using robot with activity repeated for 30 minutes. The routine involved the initial position, starting with sitting, and begin to walk while carrying a toy towards the robot. When the child arrives where the robot was, the child will deliver the toy, then touch the robot's head. Then, the robot will give feedback with positive sentences for completing the task, such as
"Right, very well done. You have done it very well. Very good, July. You have brought the toy."
The activity will then repeat the other way around, robot therapist, where the robot will give order to child to go to therapist to bring another toy. The activity is repeated for 30 minutes, and it has been implied that repeated exposure to the social assistive robot proved to be beneficial in increasing engagement, as most of the children became more comfortable with the social assistive robot over time. Furthermore, children with cerebral palsy prefer robot over parents when doing exercises. Nevertheless, there will be a need of additional support from the therapist to complete the task. As for the home-based bimanual training, it includes 2 phases, which are preparation phase and home-based training. The preparation phase comprises of assessment and goal setting. For home-based training, introductory meetings between parents, child, and coaching professional. Then, the therapist will design an individualized program according to performance measures through video recordings, and will then proceed with instruction of parents and home visit by therapists. The home-based training involves training either through implicit or explicit teaching style, video recordings, registration, and telecoaching and home visit by therapists, and also remedial educationalists. It has been discovered that home-based training could improve parent-child interaction in children with unilateral spastic cerebral palsy, and throughout this program, it allows caregivers to increase personal involvement in their child rehab. However, the caregivers does not have same expertise as therapists. For the variable of study on social assistive robot is walking ability with parameters of number of steps without falling. However, the authors did not take into consideration of any confounding factors that could affect the parameter of the study, such as walk speed or stride length. As for home-based bimanual training, the variables include teaching strategies, implicit or explicit, upper limb performance skills and level of parental stress, while the parameter involve intensity and complexity of the training. The outcome measure that have been used in the robot trials is goal attainment scaling that involve a goal section and has been proven to have excellent inter and intra-rater reliability to be applied in pediatric rehab. While outcome measure used by home-based training are COPM, Child Adapted Version, a performance measure, GAS, Assisting Hand Assessment AHA, Perceive, Recall, Plan and Perform PRPP, System of Task Analysis. COPM has been used as the outcome measure to set the treatment goals of this program, where they identify the child performance correspond to their needs. As for the results, it was found that the child present with an increased number of steps carried out continuously during the training mediated by the humanoid robot, but no other parameter has been analyzed. They only analyzed the number of steps without looking at walking speed or stride length. For the home-based training, there are yet no outcomes has been produced, but it is proven that home-based training offers the possibility to become more engaged in the therapy of their child. There are several limitations in the social assistive robot case study. Firstly, there is unclear factor of increasing number of steps, either the motivation generated by the presence of robot or any other factors. Second, there are no specified data on total of attempts being made by the children in each intervention session, and there is no variety or modification of task or environment as no progression involved throughout the session, and the therapy is only limited at neuro rehab department. For home-based bimanual training, there are no standardized component of intervention in the treatment as the program is individualized, and caregiver may misinterpret or misuse the technique of treatment that have been trained. As for the conclusion, which intervention approach would you prefer the most and why? I would choose social assistive robot because it is an interesting and motivating intervention that helps to improve participation of child with cerebral palsy and also helps in inducing neuroplasticity. In contrast with home-based bimanual training that include parents' involvement in treatment approach, they tend to give direct and strict command that may lead the child to easily get bored and shows no interest. An assistive robot could help the children to think the therapy as play activity instead of task-oriented when come to a therapy. By using an assistive robot, children will have the authority to make decisions with guidance from the therapist, able to develop logical and creative thinking skills through play, and a social interaction skills also can be enhanced. I think that's all from me. Thank you.